to address. What are the major challenges that we face as we treat HD? The first, obviously, is the lack of a definitive treatment. So really we're dealing with a disease for which we don't have a proper treatment, and then that leads us to the question, how do we manage a disease which cannot be cured? It requires a different philosophy. So it requires a different approach from the physician who's treating these kinds of problems, from the caregivers, and from those who actually suffer from the disease. So as a physician, you find the kind of physician who likes to treat an infection, say strep throat, with penicillin and expect a cure in a few days, then I'm going to be very frustrated. So I cannot have that kind of approach to these kinds of diseases. I have to have a different kind of philosophy. The other major challenge is which way forward are we moving in developing treatments, and I will try to talk a little bit about this as we go along. So, when we talk about management, we're not talking just about drug treatments. Management involves much more. It certainly involves drug therapy, but you cannot stop there. You have to move on to addressing issues of a psychological nature, of a psychiatric nature. These need to be addressed and treated. You need to look at social supports. And above all, you need to remember that in this condition, it's not only the individual we treat, but the whole family unit. This is a disease which affects the whole family. And the whole family unit needs assistance. What are the treatment possibilities in any neurodegenerative disease, HD included? We do have the symptomatic treatments. We try to reduce symptoms. We try to reduce these involuntary movements, for example. We try to treat the psychological issues, and the psychiatric treatments such may be necessary to treat depression. So symptomatic treatments don't cure the disease, but are extremely important in improving quality of life. Because if you treat some of these symptoms, you have a better quality of life for the individual. Other possibilities include neuroprotective and neurorestorative treatments. And neuroprotective treatments involve trying to protect the cells, the brain cells that are dying out in this condition. Can we do something to try and protect those cells to influence the progression? And neurorestorative treatments try to restore, or perhaps try to go in the direction of restoring the brain to its original state. It's a real challenge, but these are new ways of looking at neurodegenerative disease. Eventually, of course, we're hoping for a cure, but we're not there yet. Let's take one of the drugs that has been used, and as I go along, as I said, I want you to remember that while I'm talking about drug treatments, I by no means think that drug treatment is the end-all and the be-all and end-all of this type of management. But I will be, of course, focusing on drug treatments. Tetrabenazine is the only FDA-approved drug for treatment of Huntington's disease. And tetrabenazine is a drug which depletes dopamine in the brain, and by doing so, we hope to reduce some of the movement problems and other problems that you see in Huntington's disease. The Huntington study group carried out a study which compared tetrabenazine to placebo, And in that study, they showed that there was a 23.5% reduction in chorea in the treated group as compared to the placebo group. So it was effective in reducing chorea. The other interesting thing about this was that there was no tardive dyskinesia. If you use drugs which block dopamine, you often end up with other movement disorders which occur way down the road. And you see that in people treated with dopamine blocking agents which are used in, say, schizophrenia. You get these involuntary movements, often around the mouth and the tongue, as well as the limbs. And this is called tardive dyskinesia, which is very, very difficult to treat. And this occurs several years after exposures to some of these dopamine blocking agents. And the advantage with tetrabenazine is that it doesn't seem to do that, so that was a good thing. On the negative side, there's a real risk of depression, and this drug, tetrabenazine, depletes not only dopamine but also other neurotransmitters such as serotonin, norepinephrine, and as a result of that, one can end up with severe depression, and that is a risk with this drug. Also, this is a very costly drug. It's not available to everybody because of the cost. Now, the interesting thing about this, and this is something which I'll address when we talk about clinical trials in general, this study showed an improvement in the chorea, but when you looked at the functional checklist, which is something that was included in the study, you found that there was no benefit. So in other words, this drug seemed to reduce chorea, which was a target symptom, but did it help the person to function better, to get up in the morning and shave and brush their teeth and do all these kinds of things? No, it didn't. In fact, the functional checklist actually showed a slight lowering of function. So I think the point I want to make there is that you cannot look at one little target symptom and say, oh, this drug really works, because that's not good enough. You have to look at a wider picture. What are the other drugs that are used? Well, all the antipsychotic agents have been used, and these were the ones that were perhaps used first in treating HD. There are a variety of these drugs, most of which are derived from, most of these are used in treating schizophrenia, for example. So haloperidol has largely fallen out of favor. It is a kind of a backup drug, but it does produce a lot of side effects. I won't go into all of those. Fluphenazine. Pimazide is also an anti-psychotic drug, which is easy to use because it can be given in a once-a-day dose. And there are some small studies suggesting that this is helpful in reducing involuntary movements. Sulpride is not a drug that we have, but it's been used in Europe, and there's a European study going on comparing sulpride with some other drugs, including tetrabenazine and other neuroleptics. Results not available. Clozapine is an interesting drug because it's a drug with which might be helpful in reducing not only chorea but also helping with some of the behavioral issues. But it's also a drug.
Olanzapine has quite a severe side effect.
Olanzapine? Yes, that's right. Now, clozapine, though it has a major side effect in lowering the white blood count, so that has to be used with a great deal of caution. You have to have a blood count every week. So these are some of the difficulties. Olanzapine, as you said, does have significant side effects, sedation being one of those, worsening, bringing out a syndrome which looks like Parkinson's disease with stiffness and tremor. So these are difficult drugs.
Have you heard of something being unanswered to me that was, I don't know, not on there for very long, but it stopped going to the bathroom. Like they were, the doctor said that's an unusual side effect, but that's what happened in my case.
It's almost like a bowel obstruction, that kind of thing.
Yeah, it urged to go, but nothing happens.
I see.
And it was quite severe. We had to take them to the hospital for that. And they were quite surprised that it lasted positive.
Right, now it's not a commonly described thing, but it's certainly
Very odd.
So these are drugs that are used and are probably fairly commonly used in HD, but there are problems. So those are some of the challenges, the side effects. Other agents, there are NMDA antagonists, and the NMDA receptor is targeted here. This is involved in glutamate transmission, and it seems that glutamate, which is an excitotoxic compound, may actually lead to degeneration of some of the neurons in Huntington's disease. So if you can block that receptor, maybe you can slow down the degeneration of these neurons. So NMDA receptor antagonists have been tried. One which has been used fairly commonly is amantadine, that's available on the market, and there are some benefits shown, but the studies are contradictory. Memantine is a drug which has been used in Alzheimer's disease. It works in a similar way, and there are some small studies which show benefit. So all of these compounds are being used, all of them have been studied, but not in great depth, not in large studies. Just to talk a little bit about the omega-3 fatty acids, EPA, being the main component. These compounds may have a mitochondrial stabilizing effect. So it seems to stabilize the mitochondria in the cell. There was a 12-month study which compared the use of EPA versus a placebo, and there was no benefit shown. However, when they looked at the results in a different way and looked at subgroups, they noticed that if you took the people with CAG repeats of less than 45, so maybe a less aggressive form, there was a benefit. But if you looked at people who had more than 45 CGA repeats, the benefit seemed to be lost. So if you look at the study and look at all the patients, you might lose some results which may be there in favor of a subgroup. So clearly this is an area where you need more studies. So how can we intervene in HD in order to really make a difference? At a gene level, is it possible to turn off the mutant gene? And this is, of course, where we get into RNA silencing, and I'll come to that in a moment. Is it possible to turn off the gene which is causing the problem? At a cellular level, is it possible to protect the cells that are dying out? And I did mention the neuroprotective strategy. And then, can we replace nerve cells which have already died out? So these are different approaches. So what do we do in terms of turning off the mutant gene? So just to put it in very simple terms, and we've had other speakers talking about this, what seems to happen is this. There is a mutant gene in Huntington's which sends messages to cells to produce an abnormal protein. And so this is an abnormal form of Huntington proteins. So Huntington is the protein involved. So there's an abnormal protein which accumulates in brain cells and causes dysfunction and causes eventual death of these cells. So that is the sequence, the abnormal gene producing an abnormal protein which then causes damage to specific areas of the brain in Huntington's disease. Okay.
Is Huntington similar to Alzheimer's?
No.
Like did Alzheimer's, are their neurons or whatever dying out too also?
Yes, and what they have in common is that they are both neurodegenerative disorders. They're disorders in which brain cells are dying out. The mechanism in which they die out is different in these different diseases. Also, the particular area of the brain involved is different. So that brain cells dying out in one area of the brain may cause, through one mechanism, may cause something like Alzheimer's. Brain cells dying out in another area of the brain through another mechanism may result in something like Huntington.
Something I heard, I don't know, had to do with someone at Goodness Me had a husband with Alzheimer's, and they're really promoting coconut oil.
Oh yes, right.
And she gave her husband, like he couldn't draw the clock, okay, draw the numbers properly on the clock or whatever. And she gave her husband a teaspoon a day for 2 weeks. And after 2 weeks, he could draw the clock and all the numbers.
Right.
And he said it was like a fog lifted from his brain.
Yes, and that's an interesting area. This coconut oil has to be looked at more. It appears that if you use that, you've got to be careful to use a very pure form of this. Again, and I'm going to discuss these kinds of compounds later, but we don't have final results of that.
But it's being looked at.
But it is being looked at. So, if you turn off the gene, what happens? Well, it may be that you're turning off something which is crucial. So if you turn off the gene which produces Huntington in embryos, you cause death in the embryo. So that turning off the gene is not as simple as it sounds. You're turning off something which you want to turn off, the abnormal type of Huntington, but you may also be turning off something which you don't want to turn off. And we don't really know what the role is of the normal form of this protein, because we're here talking about a mutant form of the protein, right? What role does the normal protein play? We don't know. So what do we do? What do we risk in turning it off? So these are some of the challenges in turning off gene science. There are studies which have been done in RNA gene silencing. So as I said, the whole idea is to turn off that type of gene. There are mouse models and rat models which have successfully been able to turn off the gene and reduce the accumulation of abnormal Huntington, and this looks very promising because it looks as if by doing that you can actually reduce cell damage. But these are animal models, so that's a long way away from actually prescribing this for patients. The other thing is the mode of delivery. These agents are not agents which you can simply take in the form of a pill. They have to be introduced directly into the brain to work, which means actually an invasive procedure. there are different types of these drugs which are being developed, the RNAi drugs, which are similar to the natural RNA, the messenger RNA, which is the message which goes to the cell to produce this abnormal protein. These are similar, so it may seem more physiological to use something which is similar to the natural situation. But the other group of drugs, the ASO drugs, which are not the same as the natural product, seem to be better absorbed by cells. So there's a lot of work to be done to see which kind of drug is going to be effective in this process. Other questions which arise in terms of gene silencing. One question is the target. Now remember that genes occur in pairs. So there's a pair of genes, and in Huntington's, one of those pairs is abnormal, and then you have a normal one as well in that pair. Are you going to silence both genes, the abnormal plus the normal one, or do you want to target only the abnormal one? It's much more difficult to be selective and to silence the abnormal gene. So that's a challenge, it's not easy. If you simply target both genes, are you going to turn off something you don't want to turn off? So these are our challenges as we go forward. The destination. How do you target the right area? So now, going back to that, what I said earlier, you're producing this abnormal protein. It's going to certain parts of the brain and causing damage. Now, we still don't know why this abnormal Huntington protein affects certain crucial parts of the brain, because it's not going everywhere and damaging everywhere. This protein is targeting the striatum and the cortex, which are the areas of the brain which are most involved in Huntington disease. Why does this abnormal protein target these particular areas and not other areas? We don't really know. So this is a problem. And therefore, the drugs which we produce have also got to be selective in where they act. Just to mention briefly some problems with the delivery system. How do you get it into the brain? It's possible to deliver it in the form of a virus, like a retrovirus. Is that a good way of producing it? How do you, if you go directly into the brain, how do you make sure it gets to the right areas? We also know that putting the drug into the brain doesn't actually reach every part of the brain, so you have to sometimes give it under pressure. And that way you make sure that the drug spreads to the required area. So these are all questions that arise. So, is research needed? I don't think that anybody would question that. We do need research. We do need to move forward with more knowledge. What kind of research can be done in Huntington's? I want to spend a little bit of time talking about that. The basic scientists are those who work on the genes, who work in labs, who work with animal models, and this type of work that they do is very important. But basic science research alone is not enough. Clearly, we, as clinicians, those of us who are working in clinics and working at a clinical level, benefit from the basic science work, but we also want to see something which is more practical. We need to apply that knowledge. So clinical research can take many different forms. Epidemiology is one type of clinical research. So you look at populations of Huntington's, you look at groups and see why is it that this person has Huntington's and may have the same number of CAG repeats as this other person, and yet person A has a much more malignant type of disease. It's going much more rapidly, and person B is not going quite so rapidly. Why is this? Can we look at populations and see if there are patterns established? Is one type of the disease being inherited through the maternal side and somebody else is getting it through the paternal side? Are there differences? And this is where epidemiological studies can be helpful. Next, another type of clinical research is it takes the form of clinical trials. And finally, we need to, when we develop drugs, we need to test them and see if this drug actually works. So I'll talk a little bit about the HEART study, which is a study which I was involved with. This is a study which was run through the Huntington Study Group, through the University of Rochester. It's a multi-center North American study, which compared, there were 4 groups in this study. There were 3 groups which received different doses of this drug, which was ACR16, and 1 group which received a placebo. So you had a chance of being in one of those 4 groups. And this was run by Neurosearch, which is a Swedish company which developed this drug. ACR16 is an interesting drug in that it's a dopaminergic stabilizer. So as I said, most of the drugs that we use block dopamine. So I talked about tetrabenazine, I talked about these drugs like olanzapine and other neuroleptics which block or deplete dopamine. Now it seems that blocking dopamine produces problems and may not be the complete answer. And ACR16 is different in that it both enhances and counteracts the effects of dopamine. So it seems to stabilize. It's a dopamine stabilizer. So it's a much more complex drug than a simple drug which blocks dopamine. Many of the studies that have been done to look at treatments look at what we call positive motor features. And positive and negative don't imply a good or a bad effect. Positive means that there's an excessive movement. There's chorea, there's dystonia, and most of the studies have looked at that. However, there are also negative motor signs in HD, and that means the lack of movement. So not only the excessive movements, but also the lack of movement. And in fact, it was hypothesized in this study that some of those problems, the lack of movement, may be causing even more difficulty than the excessive movement. So you don't always target what is obvious. You know, you think, okay, there are all these movements, we're going to stop those movements and everything's going to go well and the person is going to have a better life. Well, maybe not. Maybe it's something which is unseen. Maybe, as in this case, it's the negative movements, the lack of movement, which is causing the most amount of disability. And it was hypothesized that ACR16 may actually help with the negative movements and therefore help the person to function better. The preliminary data, we don't have all of the data yet, it's still being analyzed, but it did show the preliminary data based on the studies which we did both in the US and in Canada and other studies in Europe, that there was an improvement in hand movements, the coordination of the hands, the movement, some of these movements were helped. Gait and balance were improved, so these were helpful. Also, interestingly, there was less of those side effects, depression, sedation, these kinds of troublesome side effects which you get with a lot of the dopamine blocking agents were not seen in ACR16. Now, here's a problem. When you run a clinical trial, you use some kind of measure. And you use perhaps a scale, as is the case in these studies. And what was used is a thing called the total motor score. In this study, they used a modification of that scale called the modified total motor score, so MTMS. It was the outcome measure that was used, and on that score, it failed, ACR failed to show an improvement. But when they looked at the results and looked at the traditional total motor scale score, there was an improvement. So here are contradictory findings. So what I'm trying to say here is it's very important to know what you are measuring. And depending on the scale you use, you may actually miss benefits and overlook some of these benefits. Anyway, suffice it to say that ACR16 is an interesting drug. It may have a role to play in treating Huntington's, and it may address some of the negative the motor features which have been overlooked so far. This drug has recently been acquired by Teva, and it's been named, it's now got a name, Huntington, and Teva then plans on doing more trials to address some of these issues to see if this is a drug that can be helpful. There are several other studies. There's a CREST study, which is ongoing and I believe will end in 2016. And this may be a neuroprotective agent. This is creatine. Creatine could be a neuroprotective agent which may help to slow down the progression of HD. Other studies involve drugs such as Dimebond, which started off as an antihistamine, but was used in Alzheimer's disease. There's a study going on there. Memantine, I mentioned, Celexa, an antidepressant, which may have some benefits overall in HD, and several other compounds, including nerve growth factors and so on. There are several ongoing trials in HD, and so it's good to know that options are being considered. Cell transplantation. So I talked about neuroprotection, and I also mentioned neurorestoration. Can we replace some of the brain cells which are already damaged and have already died out? And what we're most interested in are the spiny neurons, what are called spiny neurons in the striatum, that part of the brain. Attempts have been made to transplant cells, and the most common substance has been human fetal tissue. So human fetal tissue being implanted to try and take over the cells which are now damaged and dying out. There have been small pilot studies done in fetal cell transplantation. The studies are really too small to draw any really good conclusions. Clearly, more studies are needed and they need to be standardized. So, let's talk a little bit about some practical aspects. So one of the issues that I am faced with as a physician treating Huntington's is that somebody will come in saying, I've seen this drug on the internet, should I take it? You know, these kinds of issues. And these are legitimate questions. Should people be taking compounds which might have a beneficial effect. And the coconut oil, which you mentioned, is an example that is a very legitimate question. Well, this is a very, very tough question to answer because most of these drugs are aimed at disease modification. If we don't have a cure, it's reasonable to try something, to try and modify the outcome. It's a reasonable thing to do. But we don't have the data yet. In order to answer that question, we need large controlled studies which show a clear benefit and fail to show bad effects. We have to have studies which show benefit and a lack of adverse effects. And those studies are not available. The other problem with this is that the doses of these compounds is unknown. So it's really not clear how much of a compound one should take. A patient would come to me and say, should I take coenzyme Q10? Okay, well, we don't have the studies yet. But how much do I take? Well, we don't really know. Those studies have to be done. Is it, do we take 2,400 units of CoQ10 or do we take 240 units? 240 milligrams. So the doses are not established. You have to have dose-finding studies as well. The time of initiation, do you start these compounds early on as soon as Huntington's is diagnosed, or do you wait for manifest Huntington's and then introduce that? We really don't know. So these are some of the issues that come up in advising people. We really don't have the data. There's a tremendous need to have more data, and then we will be able to make informed decisions. So just to wind down this talk, I thought I'd talk a little bit more about clinical trials, because I think that clinical trials are important. And without those trials, we cannot answer the questions that are raised. Is the drug effective? Should I take it? What are the dangers? What are the side effects? And without that kind of database, without that kind of knowledge, it's very, very hard to give advice and for somebody to make an informed decision. Clinical trials are important. And I'm involved in clinical trials in different areas of neurodegenerative diseases, Huntington's, Parkinson's, Alzheimer's, and so on. So, what do they involve? Most clinical trials require placebo-controlled studies. And for a drug to be approved by the regulatory bodies such as the FDA in the States, or by our regulatory body which is Health Canada, they require the gold standard, which is a placebo-controlled study. You can have trials which have a different design. You can compare two drugs and say this drug A is better than drug B, and measure outcomes and show benefit. But the gold standard is a placebo-controlled study. Does treatment with compound A do more for this patient than no treatment or a placebo treatment? So placebo-controlled studies are the gold standard. So if you were to participate in a clinical trial, there's a good chance that you might be on a placebo for at least part of its time. Some of these trials allow the individual to go on in a blinded part of the study, which is a double blind. That means the patient doesn't know what they're on. The investigator, the physician, does not know who's on the placebo and who's not, so they're both blinded. and then eventually, at the end of the double-blind study, some of the trials allowed the individual to get on the drug in what's called an open label study. And then we both know what you're getting and how much you're getting. So if you can get into a study which allows you, if you get into a study which is double-blind, you may say, well, it's a waste of my time, I may be getting a placebo, what's the benefit to me? And that's reasonable. Other people may say, well, I don't want to be a guinea pig, I want to wait till the study is, till the drug is approved, and then I'll go on the drug. So these are different ways of looking at the clinical trials. If you go on a clinical trial which allows you at the end to have access to this drug in an open label fashion, well, there may be some benefit to you then. But these are some of the challenges of going into clinical trials and also some of the potential benefits. But I would say that without clinical trials, we will never know if these compounds are beneficial, are they safe. These important questions need to be answered through clinical trials. So I'm going to stop at that point, raise some questions and raise some points for discussion. And some of you have possibly participated in trials, some of you have probably been exposed to the drugs that I've mentioned. These are all treatment challenges.
Dr. Mendis, I'm just wondering if you have any suggestions as to how we can motivate some of our patients and families to consider a trial when they're not that willing to kind of commit to the time commitment that involves, or distance or other factors might factor in.
Yes. And this is a real problem. Here is a family coping with a disease. There are all kinds of demands being placed upon them, and just getting by day to day is a challenge in itself. Can they now commit themselves to a trial which involves traveling and coming up regularly, and so on? And this is very much an individual choice. One thing that I can say is this: there have been studies of clinical studies. And the interesting thing is that people who participate in clinical trials do better than people who do not participate in clinical trials. Why is that? Well, there could be several explanations. It could be that there's a placebo effect. And we don't, very interesting, we don't really know much about the placebo effect. Is it that having a cause for optimism, having a more optimistic approach, maybe this drug's going to help me, maybe that has an effect on brain chemistry. We don't know. Maybe there's some effect that we don't fully understand yet. But for whatever reason, people who go into clinical trials do better. Maybe that placebo effect. It may be that there's better medical care in the sense there's closer scrutiny, and the person is getting more, standardized type of treatment. It could be that. It could be a whole host of things, but what is known is that there is a benefit to being in a clinical trial.
Just a comment that I wonder, I've seen this in one person who's involved in a clinical trial, is the finances who are proper, having to travel to a different city to participate and so on. And I don't know how the funding works for a lot of the clinical trials, but in this instance, it was an issue, and maybe that's one of the blocks.
But yes, that is a
looking
common.
at future expense of a nursing home or whatever. All that's would be in somebody's mind. So added expense isn't going to help.
Well, if people on disability, a benefit incomes as well, that also gives them.
If you are in a clinical trial, ask the investigator that question, because many clinical trials actually allow travel expenses. They compensate you. If you're traveling from a distance, and I work in Ottawa and Ottawa and Kingston, and then we have people from the surrounding areas who have to come in, and those people do need to be compensated. Yes, a lot of if they're industry sponsored trials, they usually make allowance for that and compensate. So if that's an issue for anybody, you should always bring it up with your study coordinator or investigator.
Can I ask you a treatment question?
Sure.
You were mentioning at the beginning of your presentation a number of the drugs that are used, and I believe you also mentioned about anxiety and how common that is. And I wondered if you could comment on commonly used, or if there have been any particular medications in particular that are found more helpful for Huntington's anxiety.
Very good question. And again, there's a real lack of data there. One of the drugs that has been used is Effexor or venlafaxine, which is actually an antidepressant, but it may also have a beneficial effect on anxiety. So anxiety, depression often go together.
Right. Yeah.
So there is a study which shows quite a striking benefit with venlafaxine in Huntington. The rest is based on empirical knowledge. So we do use these neuroleptic agents, which can reduce that free-floating severe anxiety, but they do have side effects. We're not extra keen on minor tranquilizers, like, benzodiazepines and so on. We're not terribly keen on that, but I have used them because it does make a difference. There's a potential for addiction and so on and so forth. But bearing all that in mind, it sometimes improves quality of life.